Thank you, Susan, and thank you everyone for being here. It's my pleasure to present this talk that I initially created for the European Society of Veterinary Orthopedics and Traumatology conference in France late last year, and then to update it and bring it to you with its current information. Thanks also to Zomedica for hosting this webinar. So with that, let's get started here. As disclosure, as mentioned in my bio by Suzanne, I do consult for firms that offer services to the field, but there are no conflicts of interest related to this presentation. So, we've all been using modalities for many, many years to help us improve the outcomes for our patients. Looking to limit impairments and improve upon their final functions. It's been used by both rehabilitation and physiotherapy or physical therapy professionals, primarily to look at reducing swelling and pain, speeding healing, helping us to get back to full muscle strength faster, improving tone, and perhaps improving the elasticity of some of our tissues to allow us to get better flexibility. But I think the key message here is that we use our modalities to prepare the tissues for the big work that we do in rehabilitation, which is Therax and the manual therapies. So I cringe sometimes when I see protocols where people want to have a dog come in just to get laser therapy over and over, or to have any modality done, when it's not really being done specifically to prepare the tissues or to improve the chances for those tissues to heal rapidly and to allow us to get into the real meat of the work, which is the Therax and the manual therapy. So how each of these modalities works and how deeply they can penetrate into the target tissues is really dependent on what form of energy, and we'll look at all the different forms and how they're applied. So let's start with the basics, the simple ones, the ones that we've used for the longest, and that would be thermotherapy, both heating and cooling. Starting with cooling or cryotherapy, we know that there's many different ways we can apply superficial cold to our patients. Ice packs, cold compression, which is the device shown here, ice massage, or immersion in ice baths. We know that we can use these techniques to cool tissues up to about 2 to 4 centimeters of depth at maximum. It results in cutaneous vasoconstriction, which then helps us to reduce the inflammation, helps reduce pain, minimizes our muscle spasticity. We know from human work that we can get stronger muscle contractions during functional movements if we're using cooling as a prep for that. And of course, we use ice to limit, or cold to limit delayed onset muscle soreness. Then if we look at heat or thermotherapy, again, there's many different ways that we can apply heat superficially using different types of tissue devices. We can heat tissues up to about 3 centimeters in depth. Our greatest effect, of course, is going to be superficially. So in that first 1 to 2 centimeters. We use this to help decrease spasticity, reducing pain. It does increase blood flow to the area. We use it to try to improve on joint mobility and to relax muscles that are spastic. Draper's group in '98 showed pretty clearly that if we can increase the tissue temperature by 2 to 3 degrees centigrade, that'll help to alleviate some of the muscle spasm and pain that we see with chronic inflammation. We need to increase it to 4 degrees centigrade to promote collagen extensibility. So where's the evidence? What do we have that says we're doing the right thing using these modalities? On the veterinary side, Kivas et al. In 2016 showed very clearly that cold compression, so this is intermittent compression with constant cold, used post-TPLO gave much more effective results in reducing swelling than the typical ice packs alone. And this was a randomized clinical trial. Szabo followed this up in 2020, looking at cold compression, again, constant cold, intermittent compression, to look at limb function after stifle surgery, and showed that it improved the limb use. On the human side, Jenna's group in 2019 did a systematic review. This was looking at cryotherapy on short-term recovery in athletes. And for any of you who have been a hard charging athlete, if you're like me, these results were not my favorite, because the last thing I wanted was to be dunked in a cold water bath. But they showed that cold water immersion had greater benefit on recovery than just a passive recovery. Interestingly, Kawashima's group in 2021 published a paper looking at, it's titled Icing After Eccentric Contraction in Mice. This is eccentric contraction taken to the point of actual muscle injury, so muscle strain or rupture of muscle tissue. And what they showed was that if you iced after this muscle damage, it resulted in blunting of the efficiency of muscle regeneration. So it starts to make us think, we pretty typically see one of these severe strain injuries where you can see some hemorrhage sub-Q, and you really want to jump in there and just stop it all and put it on ice. And it turns out that may not be our best approach. At this point, there's no systematic review looking at this concept, but several papers suggesting that icing may not be such a good thing after healing, in trying to heal muscles that have been injured. This is not talking about muscles that have just been strained or stressed by exercise, but really have been taken to the point of rupture. On the human side, Brado et al. In 2016 did a systematic review looking at all different types of conservative management for low back pain. And they showed that thermotherapy, had some short-term effectiveness, somewhere less than 6 weeks. In a Cochrane review of heat and cold, looking at this for OA of the knee in human patients, they found lots of good results, that ice massage was better than control at affecting the range of motion, function, and muscle strength. Cold packs could indeed reduce swelling. Interestingly, they showed in this review, hot packs had no beneficial effect on edema when compared with placebo or cold. They did show that ice packs were not that effective on pain compared to control in these patients with OA. And it's a Cochrane review, so of course the last statement is always, we need better studies. So the controversies that we have related to thermotherapy: should we use ice after a muscle injury, one where we've actually got a strain or an injury? The evidence is suggesting that we move away from this concept. How about ice and compression after surgery? Yes, we still have clear evidence that this is the way to go. So post-op is different from post-rupture. On the heat side, we know that the optimal way to increase tissue temperature is really through movement, through activity of the muscle itself in the patient who's capable of doing that. So adding external heat rather than having the patient move if the patient is capable may not be our best approach. There's also strong evidence suggesting that we move away from our historic use of RICE, rest, icing, compression, and elevation, and really move more towards a gentle activity for these patients. Our next modality is therapeutic ultrasound. So here we have sound energy at specific frequencies that we use to impact tissues either thermally or non-thermally. So for the thermal impact, this is when we're using the device in a continuous mode. And here what happens, the tissues get this mechanical pressure wave that creates this kinetic energy that translates into heating. We know that the heating is greatest in tissues that have a high protein content, so we want to keep that in mind when we're using this modality. The good thing with therapeutic ultrasound is that it can drive heat into deeper tissues than we can with those external heat sources, and we can focus it to a specific tissue depth, so we don't have to cook the exterior to get to the interior. So therapeutic ultrasound can heat up to 5 centimeters in depth, where our external devices can only get us to 3 centimeters. The non-thermal method for using therapeutic ultrasound is when we have it in the pulsed mode. And here we end up having 2 different effects that we use to our benefit: acoustic streaming and cavitation. So acoustic streaming is when we have these little pressure waves that impact the fluids around the cells. And then cavitation is when we have this more sort of explosive compression and expansion of the gas bubbles in those body fluids. These two activities then modify our cellular function, and they modify permeability of the membrane. The resulting effect is to improve tissue repair and reduce swelling. So where's our evidence? Acevedo et al. In 2019 did a prospective crossover study. What they did here was essentially heat the calcanean tendon on one leg of the dog and use the other calcanean tendon as a control. So as they heated the one, they then tried to do tarsal flexion with both to see if there was a difference between the control tarsus and the treated tarsus as far as lengthening of the calcanean unit. So to test this, they used 4 different settings on heating the one tendon. They used, so let's call them high and low. So 1.5 for high and 1.0 watts per centimeter squared in a continuous mode, and then 1.5 or 1 watt per centimeter squared in a pulsed mode. And they recorded the tendon temperatures as they did each of these treatments. So then they, as I said, they watched the contralateral side and did tendon flexion or tarsal flexion and measured the range of motion changes. They did this before treating, after, or immediately post-treating, and then 5 minutes post-treating with the ultrasound. What they found was the continuous, so the heating ultrasound at the highest power, 1.5 watt per centimeter squared, resulted in the greatest amount of tissue temperature change while still maintaining a safe zone, not cooking any of the tissues. And they found that this resulted in their having a transitory increase in extensibility, so tarsal flexion ability. And their conclusion statement from this was that stretching exercises should be performed during and immediately after the therapeutic ultrasound is used. On the human side, a little less exciting. The Cochrane Review for knee OA said that it may be beneficial. We just don't have great quality of evidence at this point. We're uncertain about the magnitude of the effects on pain as well as function, but they note it is widely used on the human physiotherapy side and with potential benefits, and it may be clinically relevant. And of course, it's a Cochrane Review, so let's have more studies. So the controversy related to therapeutic ultrasound, we know it's beneficial for deep tissue heating, which is great in those patients where they can't heat themselves. We know that controlled active exercise is actually better. So if we have an ambulatory patient that we can warm up, probably better to use exercise than to try to use our ultrasound to do the heating. However, where do we use the ultrasound rather than other modalities? You know, when do we go and pick? I think this is going to be a better case for my ultrasound. You know, is it in the cases with the tendon sheath changes and that sort of thing that we want the mechanical impact rather than perhaps some of the cellular changes that we see with laser. So that's where we still stand on ultrasound. Our next modality is laser therapy or photobiomodulation. Here, what we have is electromagnetic radiation that we know is monochromatic, so all one wavelength, coherent, so wavelengths in phase, and directional, which means a collimated beam. We have lots of options out there on the market, and they are generally differentiated by class. We also have to pay attention, though, to the wavelength that's offered in the device that we are looking at. So the class is determined essentially by the amount of power output from the device. So class 3B is 5 to 500 milliwatts of power. Class 4 is over 500 milliwatts of power. However, there's some controversy on this, and we'll talk about that in a little bit as far as how we actually classify and what the cutoff is for the power range. We know then that our wavelength, though, has to be appropriate for the disease or the tissue we're trying to reach. And so we know that 600 to 700 nanometers is going to be better for our superficial tissues, and that 810 to 950 nanometers is better for deeper tissues. So what do we know about how it works? We know that light energy is absorbed by the cell chromophores, and this results in a number of things happening. We see the production of ATP, nitric oxide, and reactive oxygen species. We know that this limits the inflammatory process and limits leukotriene activity. We know that laser will cause a release of endorphins and serotonin, also a release of growth factors and stimulation of fibroblasts. So maybe this is helping us with collagen synthesis and wound healing. And then on the pain management side, we see a lot. We see production of endogenous opioids, in addition to the endorphin and serotonin piece, inhibition of action potentials for the peripheral nociceptors, and reduction of nociceptor activation at the spinal cord level. So lots of potential for pain management here. Where's our veterinary evidence? Unfortunately, the literature that we have for veterinary medicine is kind of mixed, and frankly, in putting this talk together, it's pretty frustrating. I think the big issue here is poor reporting of the type of laser, the way it's applied, and perhaps even the dosing in the process of writing up these papers. It's not to say that we haven't tried. There are lots and lots of papers out there on laser therapy on the veterinary side. Just the question being, how are these things being delivered, and how do we compare one paper to another if we have divergent results? So let's look at a few of them. Here's a paper that was published in 2021 looking at wound area reduction in chronic wounds, so long-standing wounds in dogs using laser. Randomized trial. What they did was the controls had saline and no laser. Group 1 had saline and laser. Group 2 had saline and a multi-wave laser. What they found was that the percentage of wound area reduction was significantly better in the laser-treated dogs than in the non-laser treated dogs by day 7. And their conclusion was that using laser can accelerate chronic wound healing process with a significant reduction in wound area. This is followed last year by a study on the equine side. And here what they did was to actually create lesions in the lateral suspensory branches of horses. And then they treated 2 of the 4 lesions on each horse using a class 4 15-watt delivery daily, every day for 4 consecutive weeks. And what they found was that long-term, they had significantly better or lower scores in the laser-treated group when they looked at lesion size in these suspensory injuries. So they said then laser enables a better lesion healing than our normal conservative treatment. So that's encouraging. Back in 2012, Roger Clemens' group out of Florida looked at using laser post-operatively on hemilaminectomy patients. And they were looking at how rapidly we could get patients back to ambulation if they were non-ambulatory post-op. So they had 36 client-owned dogs, randomly assigned them to group 1, which was laser treatment daily for 5 days or until they had a modified Frankel score of 4. And group 2 was no laser treatment at all. And they showed a big difference in the time to achieve a modified Frankel score of 4 in the laser group versus the control group. There was some controversy about the quality of the study design for that paper. So this was followed in 2017 by Dr. Balagan's group in Europe, and they did a sort of a similar study. They took 32 non-ambulatory dogs, put them in 3 groups, which were standard care plus laser, rehab plus sham laser, and sham laser only. They followed them for 10 days. And they found no difference in the recovery-related variables in the dogs in these 3 groups. I have a little concern about the 3 groups and how they were decided. They were randomized, but I don't know that we have all the variables under control here with the 3 kind of categories that they used. So their answer was larger studies are needed, and perhaps larger studies with a little different study design. Then Andy Looney's group did this study in 2018, looking at using laser to treat dogs with chronic elbow OA. They treated 20 dogs. The laser was at 10 to 20 joules per centimeter squared versus a sham treatment, which was, of course, 0 joules. They followed lameness scores, pain scores, and non-steroidal dosing over the course of the study. And what they found was they could reduce the non-steroidal dose in 9 of the 11 dogs that were in the treatment group, and none of the dogs that were in the sham group. They concluded then that regularly scheduled laser treatment at 10 to 20 joules per centimeter squared per joint for a 6-week period improved lameness and pain scores and lowered the non-steroidal requirement in the elbows. So some questions arose about this study as to, how do we decide? Was it 10? Was it 20? How did we decide on that high of a dose? And was, could a crossover design be done to see if the sham dogs would improve if they were then put into the treatment group? On the human side, there's a Cochrane review for class 3 laser in human OA that was underway and was withdrawn. And this is due to lots of comments that said there are lots of other papers coming out showing positive results that need to be reviewed that could affect the conclusions that were initially in the first review. There's some errors that were made, so there's lots of work being done in the background to get a new Cochrane review completed, and so we'll have to wait for the next review on that subject. However, we do have Cochrane reviews looking at non-specific low back pain being treated with laser. And here they basically said that the populations and the way the studies were done, they couldn't draw firm conclusions about the effects of laser on low back pain. They did a review for rheumatoid arthritis, though, and said it should be considered for short-term treatment for pain relief and morning stiffness in patients who have RA, particularly because it had no side effects. But the reviewers did admonish the writers and researchers to do a better job of reporting what kind of device and what techniques were used, because they felt they didn't really have the ability to compare wavelengths, treatment duration, et cetera, from one study to the next. So our controversies with laser, class 3B versus class 4. Do we need the extra power of the class 4? I'm not sure. Do we have evidence of that? And then this controversy coming up regarding the classification system. Recently, it was brought to our attention that the FEI, which is the organization that oversees how internationally competing equestrian patients are treated, the FEI said, we're going to put up strict rules about the use of laser in the FEI barn where these horses are kept during the times that they're competing, so that they said we don't want anything that has over 500 milliwatts of power in the barn, and the horses can't be treated with that. In a later statement, they said only class 3B, not class 4 lasers can be used. So they use both language, the class as well as the power. However, we have learned that the FDA, when it looks at lasers and determines whether one is a class 3 or class 4, it's not just this hard cutoff at 500 milliwatts. They really look at how the laser light is delivered by the probe, how it is focused, and depth of penetration, that sort of thing. So we can't use 500 milliwatts as a hard cutoff in our language anymore. We have to really look at how the FDA is classifying this. So it's going to create a fair amount of controversy on the equestrian side. I don't know that it's going to impact dog sports at all, but something to be aware of. Then other controversies, the efficacy in our post-op hemilam patients. We have one paper says it's great, the other one not. So I think we need better studies. And then, are we able to compare the studies that we have out there? Are we looking at apples versus oranges because of this lack of clarity in how the devices are being applied in the study? So I think more work needs to be done. The next category then is pulsed electromagnetic field or PEMF therapy. Here we know that the magnets that are in the devices produce this electromagnetic pulse, and that interacts with the tissues. We know that this causes this release of intracellular calcium, and Gainer's group in 2018 showed that this results in an increased binding to calmodulin with an upregulation of nitric oxide, and that results in a reduced inflammatory gene expression in immune cells, reduced programmed cell death, promotion of vasodilation, and enhanced circulation. So there are different types of PEMF devices, targeted and non-targeted. The targeted waveform is designed to really get the energy to the tissue and modulate the biological signaling cascades as efficiently as possible. The devices come as loops or mats. For the horses, they come as blankets and joint wraps and that sort of thing. So where's our evidence for PEMF? Pinna et al. In 2012 used a non-targeted PEMF device and did 20 18-minute sessions looking at OA signs in these patients. And what they found was that the PEMF-treated dogs outperformed dogs who were in the control group using firocoxib. This was on a long-term follow-up. Sullivan followed that in 2013. Again, non-targeted PEMF device applied for an hour a day on 9 consecutive days to reduce OA pain. And the dogs were then assessed by owner. The caveat here is it's non-blinded and owner reported. In 2018, Zeiden's group used a targeted device and looked at reduced incision-associated pain in post-surgery disc dogs. They found that they had reduced pain, they had better proprioceptive placement, and I think the most interesting thing from this paper, they may have reduced the extent of spinal cord injury. What they did was to measure a biomarker, which is this plasma glial fibrillary acidic protein concentration. And they found that that was reduced in the dogs who had the targeted PEMF. This was limited, it's only 16 dogs, but a double-blinded placebo-controlled study. Excuse me. This followed in 2019. Leilani Alvarez's group out of the Animal Medical Center looked at owner perception of pain management in post-hemi-lamb dogs. This was a double-blinded placebo-controlled trial in 53 dogs with a targeted PEMF device and found that they had improved results. On the human side, Cochrane Review for neck pain using electrotherapies, including PEMF, they concluded they couldn't really make any statements, that the modality might be more effective than placebo. Then there's this scoping review, and we're going to look at it a couple of times, looking at all of the physical agent modalities for early OA. So this is kind of specific, not chronic OA cases. But in the section of this paper related to PEMF, they showed that PEMF reduced symptoms, both pain and joint swelling, improved knee function and activity level in early knee OA patients, all the way up to a 1-year follow-up, better in the young patients than the old, and the effects decreased at a 2-year follow-up. And then they showed that early preemptive PEMF treatment helped with bone and cartilage synthesis and helped to decrease bone and cartilage degradation in this patient group. So our controversy with PEMF, there are proprietary frequencies that different companies have. Do they matter? We're not sure. I'm not sure that we have the science on that yet. We may need to follow up on that. Do we have sufficient evidence with the papers that we've got to move forward? And then there is disposable versus rechargeable devices. I don't think that's necessarily scientifically controversial. It's more of a marketing controversy at this point, but something to keep in mind when looking at devices. So our next category then is extracorporeal shockwave therapy. Our science here, we know that these are single pulse sound waves, big ones, that help to change how the mechanical energy happens at the interface of tissues that have different acoustic impedance. So muscle and tendon, tendon and bone, etc. They're really powerful. They're about 1,000 times the pressure magnitude of our typical ultrasound wave. The good news is they can be delivered to a very controlled target, so we can look specifically at how deep we want to go with the device. We know that what happens is we get a mechanical stimulation of the cell, and then that creates this increased expression of cytokines. And at first thought, you think, I don't know if I really want my cytokines going up. You get growth factors as well, and then this converts down to a decreased inflammation, neovascularization, and cell proliferation. We've recognized for a long time that there's some sort of analgesia that happens in our patients who have been treated with shockwave. And what we've determined now is this is probably due to increased serotonin activity in the dorsal horn and a descending inhibition of pain signals. So where's the evidence? On the human side, well, actually on the bench side, we know that Shockwave will modulate neovascularization, mesenchymal stem cell differentiation, and that it releases angiogenetic factors. This group looked at the effects of Shockwave on tenocyte proliferation and extracellular matrix metabolism. So this is bench work, not clinical. And what they found was that specifically related to the healing of tendons, Shockwave shown to stimulate tenocyte proliferation and collagen synthesis. So that's always a good thing when you're looking at healing tissues. This was followed up by another study looking at the effects of Shockwave on cultured tenocytes. So again, it's bench work, but they showed that Shockwave would downregulate the inflammatory mediators, the MMPs and interleukins that we normally find in high concentrations in these diseased tendons. So anytime we can find something that'll increase healing and decrease inflammation, I think we're on a good roll. On the veterinary side, Mueller et al. In 2007 published Shockwave looking at pelvic limb function in dogs with hip OA. 18 dogs were treated, 6 untreated, and then they looked at force plate analysis to assess their function before treatment, 4 weeks post, and then again at 3 and 6 months post-treatment. And they saw significant improvements in vertical impulse and peak vertical force at 3 months after treatment in the treatment group. Dr. Millis's group at Tennessee looked at treating elbow OA, chronic elbow OA, and they assigned them either to a treated or sham treated group. And it was a modified crossover design so that those dogs who were in the sham group could then go into the treatment group after they had been treated, after they'd gone through their sham period. And their results, they saw improvements in the outcome parameters, a 4.5% increase in peak vertical force compared with a 2.6% decrease in the sham treated dogs. They also had peak braking and peak propulsion that were better, significantly better. And then the sham treated dogs, when they went back into the treatment group, showed improved scores as well. In their discussion, they point out that these improvements of 4% may not seem great, but it's about what we'd expect on force plate scores with the use of non-steroidals. So pretty dramatic improvement, actually. Then Ross Palmer's group out of Colorado State looked at Shockwave on bone healing in post-op TPLO dogs. What they did here was to take 42 dogs, it was 50 stifles, and assign them randomly to TPLO with Shockwave or TPLO with sham Shockwave. The treated group got 1,000 shocks from an electrohydraulic unit immediately post-op and again 2 weeks post-op. Then they had 3 blinded radiologists who assessed the orthogonal views taken at 8 weeks post-op. They used a 5-point and a 10-point grading system to look at bone healing. And what they found was that the healing scores were significantly higher in the 8-week post-op treated group in both scoring systems. That paper was in 2015. That was followed by this paper by Barnes et al. In 2019, looking at Shockwave on limb use after TPLO. Very similar study design, so randomized prospective clinical trial. Client dogs were assigned to TPLO with Shockwave or without Shockwave. Same dosing regimen. And here they looked at subjective pain, stifle goniometry, stifle circumference, peak vertical force, vertical impulse. They measured these before surgery, so prior to Shockwave, and at 2 and 8 weeks post-op. And the results showed that peak vertical force and vertical impulse in the Shockwave group were higher at 8 weeks post-op compared with pre-op, and that the control group had scores at 8 weeks that were lower than they were pre-op. So that's encouraging. On the human side, Chen et al. In 2020 looked at Shockwave in a systematic review meta-analysis, Shockwave for treatment of OA. And what they found was that Shockwave had a significant improvement in pain reduction and function when compared with placebo, corticosteroid, HA, and therapeutic ultrasound. They showed functional improvement and a statistical improvement compared with kinesiotherapy, and they had no serious adverse reactions. Looking back at this scoping review again, on the section related to Shockwave, They found that Shockwave applied to subchondral bone had protective effects for articular cartilage, synovium, and subchondral bone. They showed that it induced the expression of microRNA to control genes related with cartilage development and bone remodeling, and that the articular surface damage was not obvious and only mild fibrillation was observed in the treatment group. And that was followed late last year by this study looking at a comparison of Shockwave with NSAIDs and HA in early OA for knees. So they had 45 patients randomized into 3 groups. The NSAID group got celecoxib at 200 milligrams daily for 3 days. HA group was injected weekly for 3 weeks. And the Shockwave group had 3 sessions done at 2-week intervals. They followed them up for a year. All 3 groups showed improvement. The Shockwave group had better pain relief, better therapeutic effects, and significantly increased bone mineral density in their proximal tibia compared with the NSAID and the HA group. So our controversy with Shockwave, there are different types of devices out there. There's radial, electrohydraulic, and piezoelectric devices. The vast majority of the work that you just saw me present here has been done in electrohydraulic devices. And one has to be careful when evaluating the marketing materials from companies who may suggest, look, it's a Shockwave, we've got proof that it works. And they present you with papers that are done on piezo or on electrohydraulic devices, but they're not selling you an electrohydraulic device. So I think that's an area where we have to be a little cautious. Another controversy is the need for sedation. We know that this treatment can be uncomfortable and it's noisy. So for dogs that can be, and horses, that can be a little disconcerting. So work has been done now to develop devices that can be used without sedation or with very minimal sedation. And then the other controversy is optimal dosing. I think we're still trying to figure that out. So how many pulses really do we need or should we use for each type of problem? So let's look at the bottom line. What do we really know? Let's review. Cold with compression post-TPLO is better than ice packs. Hard fact, we know that. Ice immediately after muscle strain, maybe a little controversial. We know that heat reduces pain and increases tissue extensibility. We also know that active control movement is superior to external heat application. With therapeutic ultrasound, we know it heats to a 5-centimeter depth, which is great without heating the superficial tissues, and that's great for our non-ambulatory patients. With laser, we know that there's evidence for improved wound healing, both chronic and acute, lameness scores, and pain scores. PEMF, we know that we've got improved owner-assessed pain scores, maybe some spinal cord protection post-injury, and improved knee function in early OA in people. And then finally with Shockwave, we know that it stimulates tenocyte and collagen synthesis, downregulates the inflammatory mediators in tendons that are injured. We know that it has showed improved force plate outcomes in canine patients with hip, shoulder, and elbow OA. We know that it accelerates bone healing and improves lameness scores in TPLO patients. On the human side, we see significant improvements in pain and function compared to steroids, HA, and nonsteroidals, and protective effects for articular cartilage, synovium, and subchondral bone.